Chapter 3, Lifting and Moving Patients. Some of the things we'll be talking about is how to protect yourself using proper body mechanics and how to protect your patient. We'll be discussing emergency, urgent, and non-urgent moves. So let's talk about body mechanics and how to protect yourself. Body mechanics is defined as the proper use of your body to prevent injury and to facilitate lifting and moving patients. Things you want to consider before you're going to lift any patient or move any patient. What is it that we're moving or lifting? Its weight and whether it will require additional help to lift. Is this something that we can do on our own, or is it something that we're going to need a partner or even possibly an engine crew or something like that to assist us during this? Know your limitations. Know what you can lift safely and effectively by yourself or even with a partner. We may need to come up with unconventional ways to be able to lift or move an object or a patient. Communication is key. Make sure that you have a plan and communicate that plan with your partner, especially when we're talking about cot operations. A lot of cots require 2 people to lift or 2 people to even depress the lever to be able to move the cot. So if one person is not paying attention or not ready to lift, somebody could be injured. So let's go over some of the rules for lifting. Position your feet properly. You should be on a firm, level surface, and you should have your feet shoulder width apart. And make sure you're using your legs to lift. Do not lift with your back, and never turn or twist. Attempts to make any other moves while you're lifting can possibly be a major cause of injury. Also, don't try to compensate when lifting with one hand. Avoid leaning to either side and keep your back straight and in a locked position. So rules for lifting. Keep the weight as close to your body as possible. When possible, use a stair chair if you're carrying a patient on stairs. This will reduce the risk of possibly dropping the patient or causing undue injury to yourself when you have a much more effective means to be able to carry the person down the stairs. Here's an example of somebody using a stair chair to be able to move the patient down the stairs rather than either a deadlift or trying to maneuver a cot down the stairs. Once they're at the bottom of the stairs, you can transfer them over from the stair chair over to the ambulance cot. Here's a demonstration of the power lift, showing proper body mechanics, feet shoulder width apart, lifting with their legs, the back is in a locked position and straight up, and 2 hands firmly placed on the cot. When you're reaching, make sure that you're keeping your back in a locked position. Avoid any twisting while reaching, and avoid reaching more than 20 inches in front of the body. Sometimes this isn't as easy to do as we'd like, but this will be the best way to try to prevent injury from lifting and moving patients. And avoid prolonged reaching when strenuous effort is required. It can really strain the body and the back. If you're going to be pushing or pulling, we want to make sure that we're pushing rather than pulling whenever it's possible. Still keep your back locked in, keep the line of pull through the center of the body, and keep your weight as close to the body as possible. If the weight is below your waist, you want to push or pull from the kneeling position. Do your best to avoid pushing or pulling from an overhead position, and keep your elbows bent and arms close to your sides. So how do we protect our patient using the emergency, urgent, and non-urgent moves? When we might use an emergency move, things that we might consider if the scene is hazardous, or the care of life-threatening conditions requires us to reposition the patient, or if we have to be able to reach other patients. Ways that you can do an emergency move is a close drag. Especially with the emergency moves, what we want to consider is moving the patient in the direction of the long axis of the body to try to protect against aggravating any potential spinal injury that we may see. There's several types of moves that we're going to discuss. This one, of course, is the close drag. So they're going to be dragged by whatever clothes that you can safely grab a hold of. And the feet, the shoulders, you can put them on a blanket. These are reserved for emergency moves because they don't provide protection to the neck and the spine. Most commonly, the long axis drag is made from the area of the shoulders. This causes the remainder of the body to fall into its natural anatomical position with the spine and all limbs in normal alignment. Here's the incline drag. If you're going to be doing that, make sure that you're always dragging head first. Obviously, we want to try to protect the head, neck, and spine as best as we can. So if we're dragging head first, we've got much more control on that. And their feet can drag down the stairs or whatever incline it may be in a much safer and effective manner. Firefighter's drag. So the patient's going to be on their back, their hands are going to be tied together, and you're going to straddle over your patient with the patient's arms over your neck. So what you're going to be doing is basically raising your body and crawling your hands and knees, trying to keep the patient's head as low as possible. The blanket drag. You place the patient in a blanket, bind it up on one end, and roll them towards your knees. Place the blanket under him, you'll gently roll him onto the blanket, and then you use the blanket to drag the patient. Again, keeping the patient's head as low as possible. One rescuer assist. You can see here that the patient's right arm is over your neck, securely holding the right arm, and then you'll support them by their waist. You can grab onto a belt loop or the waistband of their pants or anything like that to try to get them out to where they need to be. Two rescuer assist, obviously much easier. You're going to have two rescuers. Each arm is going to be over the rescuer's neck, and you're basically assisting them, allowing them to walk, but in a safe manner. Urgent moves. Urgent moves are used when the patient must be moved quickly for the treatment of an immediate threat to life. Unlike an emergency move, urgent moves are performed with precautions for spinal injury. Moving a patient onto a long spine board. When reaching across the patient to perform a log roll, remember that the principles of body mechanics. Keep back straight, lean from the hips, and use shoulder muscles to help with the roll. We're using this if we're suspecting an immediate threat to life and suspicion of a spinal injury. We're going to place the patient supine, and we're going to log roll them onto the side. And then we're going to place the spine board next to the body, and then log roll them back onto the board. Moving a patient onto a long spine board. Once we do this, we want to lift them onto a stretcher, secure the stretcher, and load into the ambulance. Urgent moves in a rapid extrication. This is used when we're taking time to immobilize a patient with a short backboard or a vest, similar to a KED device, which we'll go over later, before moving the patient, and it may cause a deadly delay. We want to make sure that we stabilize the spine manually as the patient's moved onto a long spine board and until they're completely secured. In non-urgent moves, the patient's going to be stable. There's going to be no immediate threat to life. The patient's going to be able to be assessed, treated, and moved in a normal way, and we want to take all required precautions not to aggravate any sort of existing conditions. Keep in mind that while there's no immediate threat to life, the patient should be moved using a non-emergent move. They should be carried out in such a way to prevent injury or additional injury to the patient and avoid any discomfort and pain. Patient carrying devices. Most commonly we're going to use a stretcher, but these are defined as a stretcher or any other device designed to carry the patient safely to the ambulance and to the hospital. So you're going to have the wheeled stretchers, the power stretchers, which are very common anymore, your manual stretchers, which are still out there. Some agencies, actually a lot of agencies still have manual stretchers. Even some of the full-time departments still use manual stretchers. And your bariatric stretchers. These are going to be rated for patients weighing 800 pounds or more. Here's an instance and an example of a wheeled stretcher. This is a power stretcher made by Furno in this case. Power stretchers are designed to be able to reduce the stress of lifting and lifting injuries. So not only do they assist when lifting the stretcher from the ground, but they also assist when loading the stretcher into the ambulance. Many of the EMS agencies around here and nationwide have invested in these devices because they've seen a great reduction in EMT and paramedic injuries as a result of lifting. This one's a bariatric stretcher equipped with the ramp to be able to move them into the ambulance. Other ones we use are stair chairs. So when you're traveling down a flight of stairs or several flights of stairs, these can be very handy. It allows you for a very controlled movement down the stairs. A lot of them have a track system on the back that only goes so fast, so you line up the track system with the edges of the stairs and you move down pretty quickly and efficiently, but in a safe manner. These are also very useful where stretchers can't easily be maneuvered. You can only collapse a stretcher so far, and the stair chairs fold up almost flat, up to only a couple inches thick. Spine boards, you've got your short ones. These are primarily for removing patients from vehicles when neck or spine injury is suspected. And you've got your long spine boards, which they'll ultimately be secured to. As an example of the stair chair, again, these fold up pretty compactly, only a few inches thick once they're completely compacted. There's an example of your short spine board and your long spine boards. Other types of stretchers that you may see, your portable stretcher, a scoop stretcher, a basket stretcher, your flexible stretchers, and your vacuum mattresses. Some of these we'll go over in class later on during the hands-on portion. This is your vest type extrication device. The commercial name for it is a KED, but they're very useful in securing somebody in a vehicle, protecting their C-spine as best as we can. You can transfer them onto the board with that device, and you can actually leave the device on them during transport as well. There's your scoop stretcher. These are very handy for people that have potentially broken a hip or anything like that where it's impossible to log roll them or move them without severe discomfort. You can see the silver hinges on the top and bottom. So the spine board, the scoop stretcher, can actually detach completely in half, or you can use it as a you can just detach one side and kind of use it in a like scissor-like method. The only thing you have to be careful with here is one, pinching your own fingers, and two, pinching the patient as you slide it under them. There's a basket stretcher. A lot of times you see these in high-angle rescues and like terrain rescues and wildlife rescues and things like that. Flexible stretcher. Your vacuum mattress. So you place the patient on here, the air is taken out, and it becomes rigid, conforming to the anatomical features of the patient. Helps pad any voids that you may have based on their body style. Some things to think about. How are you going to choose the appropriate patient carrying device? Initially, it may be kind of tough. You kind of get in your head that you have to take a cot in or you have to take a stair chair in, but depending on what your agencies have, it may be beneficial to use some other unconventional methods or some different types of carrying devices. It's important to consider that when you're moving a patient to a lifting device, everybody needs to work together as a team and have good body mechanics to ensure safe lift for all parties involved. If you've got a patient with suspected spinal injury, you want to make sure to immobilize the head, neck, and spine before you move them. So you'll provide a manual stabilization, you'll place a rigid cervical collar on them, and you'll maintain manual stabilization until the patient is immobilized to the spine board. Patient with no suspected spine injury, you can use an extremity lift, used to carry the patient to a stretcher or stair chair. It can also be used to lift the patient from the ground or also from a sitting position. Extremity carries demonstrated something like this. You can also do it with the, in this case, the female EMT could also face the patient as well if you're comfortable walking backwards. Patient with no suspected spinal injury, you can do a direct ground lift. You can lift them directly from the ground onto the stretcher. These slides demonstrate the ground lift. Stretcher set in its lowest positions, placed on the opposite side of the patient. EMTs are going to face the patient, drop to one knee, and if possible, they're going to place the patient's arm on their chest. The person in charge is going to cradle the patient's head and neck by sliding one arm under the neck to grasp the shoulder, moving the other arm on the patient's back. The foot end EMT is going to slide one arm under the patient's knees and the other arm under the patient above the buttocks. If a third rescuer is available, they should place both arms under the patient's waist while the other two slide their arms up to the mid-back or down to the buttocks as appropriate. On the signal, whatever that may be, usually 1, 2, 3, we're going to lift on 3, something like that. The EMTs lift the patient to their knees. And then on the signal again, the EMT stands and carries the patient to the stretcher. Then they're going to drop back to one knee and roll forward to place the patient onto the mattress. Again, patients with no suspected spinal injury, you can use a draw sheet method. You can basically place a sheet under them or use their own sheet if they're already in bed. You kind of roll up the sides of the sheet, get a good grip on the sides, and then move them via sheet over onto the cot. Or you can do a direct carry as well. This is the draw sheet method being demonstrated. You're going to loosen the bottom sheet of the bed, roll it up, like I said, towards the patient. You're going to lower the cot into the position so you can kind of just scoot them right over. And EMTs are going to use their bodies and feet to lock the stretcher against the bed so that it doesn't move. Whenever everybody's ready, you're going to pull out on the draw sheet to move the patient to the other side of the bed. Both are going to use one hand to support the patient while they reach under to grasp the bed sheet, so that way they're not just plopping down onto the bed. This slide demonstrates the recovery position. This is for an unconscious patient in which you believe does not have any sort of suspected C-spine injury. They call it the recovery position. That way if they vomit or anything like that, most of it is going to run out rather than collecting in their airway if they're laying on their back. Positioning patients for shock. Place positions believed to be in shock in the supine position. Okay, so on their back. Do not lower their head. Do not raise their legs. Just leave them in the natural supine position. When you arrive at the hospital, you move the patient off of the ambulance stretcher to the hospital stretcher. Most commonly, you're going to use the modified draw sheet method, as demonstrated a little bit earlier. Here it is again. You're going to position the raised ambulance cot next to the hospital stretcher, and we're basically going to work as a team to move the patient over. You want to make sure that the patient's in a position of comfort, so you may either need to raise or lower the patient's head. Both teams working together, you're going to gather the sheet on either side of the patient and pull it tight, and you're going to work to transfer the patient securely over to the bed. Holding the sheet at the support points near the patient's shoulders, hips, and lower extremities, you're going to slide in one motion over to the hospital. Make sure that the patient's properly fitted onto the hospital stretcher and the rails are raised before you turn them over to the emergency staff. That way they don't accidentally roll out of the bed. We'll practice this in class. This concludes the chapter of lifting and moving. Some of the things we talked about was a process of lifting and moving patients. We know it's a task that requires planning, the proper equipment, careful attention to body mechanics so that we prevent injury to ourselves and the patient. Remember that the most important rule in lifting is to lift with your legs and not your back. Make sure that you're keeping your feet shoulder width apart, keeping your knees bent. Emergency moves are those that may aggravate spinal injuries, therefore they're reserved for life-threatening situations. Urgent moves are used when the patient must be moved quickly, but there's no time to provide quick, temporary consideration towards preventing or aggravating a spinal injury. Non-urgent moves are normal ways of moving a patient to a stretcher after performing a complete on-scene assessment and completing any needed spinal stabilization and immobilization. Positioning the patient for transport should take into account the patient's comfort, their medical needs, and also their safety. Also remember the importance of correct lifting and moving techniques on every call. This is to protect you and your patient from injury and to maintain a long and positive EMS experience. Remember that proper lifting technique is an important wellness strategy. Biomechanics and rules of lifting to help prevent injuries are associated with lifting, and there's many different patient carrying devices, so we want to make sure that we're choosing the correct device based on particular patient and the needs of that particular movement. Always remember to use the proper technique to move patients onto patient carrying devices and positioning them for transport based upon their condition. Questions to consider. Why are body mechanics so important when lifting and moving patients? Why is using an appropriate patient carrying device an important consideration? When would an emergency move be necessary? In what ways can proper positioning help a patient's condition? So you arrive at a vehicle crash and find an elderly driver slumped over the wheel. Upon examination, you determine the patient is in respiratory arrest, but not trapped in the vehicle. Which move do you think would be most appropriate for this patient? That concludes Chapter 3, Lifting and Moving. If you have any questions, please feel free to reach out to me. Otherwise, we'll practice all these things hands-on during your practical sessions.